Hi, good morning again and welcome. This panel, Justice and Health for All, will explore workforce-related factors contributing to racial and ethnic inequities in healthcare and whether increasing diversity in the healthcare workforce may mitigate these factors. So, looking at life expectancy, you can see that beginning in 1975, there was a divergence from all other developed nations from the United States. You can see, well, you can't see Japan there up at the top, kind of hidden, but USA started to diverge, all the developed nations. This divergence coincided with national policy changes that started the war on poverty, resulting in a 50% reduction in poverty, only to be reversed 10 years later to spending $60 billion in today's dollars a year less in HUD monies. And you can see the impact here. So why is it that life expectancy has been in decline? Poverty results from many types of exclusion. Exclusion from access, quality, and it's accentuated around race and other factors. Using this, and in the next slide, you can see the decline extends beyond 2017, and in fact, you can see a precipitous decline at 2017. So this is from a book, Spirit Level, from 2009, but the numbers today are even more stark. The declining life expectancy, they state, is from income inequality. We're introduced to seemingly every social determinant here. From every indicator or lens, as we look at poverty, we are at the worst in the United States in all but social mobility. But rest assured now, because this was from 2009, we're now tied for that place with the UK. In the United States, generational poverty is closely associated with geographical regions, race, and opportunities for economic mobility. In some, children and their families do better wherever there is less concentrated poverty, not surprising, less income inequality, better schools, a larger share of two-parent families, and lower crime rates. Again, income inequality is a major driver, but it is a broken system built on racist, redlining, and other practices of exclusion. And you can see here, whether it's the World Bank inequality rankings, social mobility, life expectancy, teenage pregnancy, obesity, infant mortality, murder rate, prison population, poverty rate, income difficulties, even voting rates and trust, we stand last among the developed nations. So now, probably the most important slide of sharing the context of this panel is the work in this next hour. If we're going to impact health, our efforts must include the understanding that the major drivers of health are not medical care. As you can see here, clinical care or medical care comprise 20%, but behaviors alone, health behaviors, are 30%. So concordance is seen most closely with the impact from behavior. And so in that category alone, we can see how trust, for example, could change and influence behavior. What factors can influence the feeling of trust with a provider? Is it racial concordance, cultural concordance, or many complex factors that vary from person to person? What can we do to maximize this experience for the patient? Where and what are our gaps in treatment, research, social and environmental context that influence that experience? Here are some basic principles, and Dr. Spann alluded to it moments ago. that if you're using primary care more, emergency care is used less, cost is less, and quality is greater. That's Barbara Starfield's work. Is being a good doctor good enough? Why do some people delay or avoid preventive or primary care? What are their characteristics? Are those characteristics mutable? Does Texas's highest uninsured rate in the country impact utilization in preventive and non-emergent care? Here we see the ER visits, the ER visit rates among Black persons are double those of non-Hispanic white and Hispanics. In this slide, we see that Black and American Indian and Alaskan natives are much more likely than whites to die early of preventable deaths with better access, but Latinx and Hispanic rates are similar to whites. Why is that? And now you can see on the left the racial demographics of medical doctors on the left. These are the demographics, and you can see where they're quite similar, but then you can see from the 5% of Black doctors on the left portion, and then 12% of the US population, and that is almost half of what it is in Houston. And then you can see the 7% of medical doctors on the left compared with 18%, and it's almost half of the population in Houston. And as Dr. Spann alluded to, that's partly why we exist, is to have a more diverse workforce. So then lastly, as Blacks increase in the workforce, life expectancy increases for Blacks. I shared this teaser introduction just to some of the issues with you, and it's my pleasure to now introduce our panel of 4 distinguished physician scientists. Dr. Jada Bussey-Jones, the Carter Smith Senior Professor of Medicine in the Department of Medicine of Emory University School of Medicine, and she, among other things, is going to talk about physician shortage. Dr. Mark Robinson, Assistant Professor and Associate Program Director of Internal Medicine at Baylor College of Medicine, is going to talk also about language barriers and mistrust. Dr. Angela Heads, Associate Professor, Co-Director of the Center for Behavioral Health Equity and Outcomes Research at McGovern Medical School, UT Houston, UTHealth, will talk about treatment, cultural competency, humility, and mistrust. And then Dr. Jane Hamilton, Associate Professor and Co-Director of that same Center for Behavioral Health Equity and Outcomes Research at the McGovern Medical School, will talk about health research gaps. Thanks very much.
Good morning. I want to say good morning to those of you in the room as well as those of you online. My name is Jada Bussey-Jones. As was just mentioned, I am so happy. No problem. So happy to be here with you today. I appreciate the introduction and the invitation to talk on this important issue. I don't have any financial relationships to disclose, and for the 10 minutes or so that I have with you all today, I'm going to talk about some of the key drivers, as Dr. Buck has already mentioned, around health inequities, but really kind of what supporting a diverse workforce could look like and how it could benefit us, broadly speaking, and then hopefully some strategies, some examples of things that we've done at my institution that, and just some broad thoughts about what we can do in this space of physician workforce. So the key drivers, and so many people understand, and it's already been discussed today, this idea of social determinants of health, but this modified or revised framework that was developed in 2020 by Yearby really, I think, is important for today's discussion. So if you look at the well-being in purple, the health and well-being, which is the goal, right? Then the drivers of health include medical care, what we do, which quite humbly, as Dr. Buck mentioned, is very small percentage of what happens for how long and how well that our patients live. But really those other non-medical determinants, whether it is neighborhood, housing, food insecurity, other things that are listed that have an even greater impact. But for today's discussion, we need to go deeper to look at more of the root cause, get more proximate. And so this area in black that was also alluded to, the sort of legacy of structural discrimination, whether it's racism, classism, sexism, that have driven for our partners in the legal space, the laws, the policies, the procedures that in turn build those systems that result in these more poorer outcomes. So I think we're all aware of those, but it just sort of breaks down this idea of our determinants of health in different ways. And again, it makes me think about my role, even as a clinician, more broadly. So let's talk about the supporting evidence for healthcare workforce, diversity within the healthcare workforce. I was giving rounds at Baylor yesterday, and I was talking about how when I would talk about these issues, especially as a person with multiple intersecting identities, that before I would say it's the right thing to do, social justice, that we should have representation that mirrors our population, as we were just describing. However, now, that is still true, by the way, but now I also make, as I become more of a leader and am talking more to leaders and other stakeholders, to talk about that it's more than that. It is not just for women or people of color or any marginalized group that you might mention, that as we in healthcare are trying to manage our talent, to be a great place to work, to have better patient outcomes, to have a better bottom line, to have a better learning environment, that those are the things that I believe that diversity brings, and the evidence is suggesting that as well. Our business colleagues are, I would say, one of the first to sort of dip into the understanding around how diversity can improve your bottom line. For example, this McKinsey study in 2015 showed that for every 10% increase in gender diversity, there was a 2 to 4% increase in profit. Similarly, if you have at least one woman, companies with at least one woman on the board of directors had a minimum of 4% increase in profit compared to companies who did not. And intuitively, more diversity is aligned or associated with higher innovation, different minds approaching different problems in different ways. But if we look at our book of business in medicine, which is the thing that we're talking about here today, there are a fair number of studies. Yesterday I was talking about women, so I've started off with those here. But women, for example, are less likely to die of a heart attack when they're cared for by women physicians. They're also less likely to die after a surgery or have complications if they have a woman surgeon. Women physicians are more likely to follow traditional guidelines for heart failure, diabetes, and preventive care, and more likely to ask patients about their social conditions and spend time with patients. Some of the things that around race concordance, as we were talking about, Black patients are more likely to get preventive services like vaccinations and colonoscopies when they have Black physicians. We also know that physicians of color are more likely to care for underserved Medicaid populations that have more patients of color as well. And then we've been talking about this idea of concordance. So not just race concordance, language concordance, gender concordance has been associated with better patient engagement scores, which in turn has been associated with better outcomes, adherence to therapy, trust, which we'll talk a bit more about in a moment. Infant mortality has been associated with race concordance as well. MI outcomes and the like. Those are just a few examples. And then the study that Dr. Buck just mentioned where there is, I'm very partial to this, by the way, because I am a primary care provider. The things that I will note in addition to what he said is that, first of all, in less than 50% of the counties in the United States, that there's still not even one Black physician, so that's one thing. But when there is a linear relationship between the number of Black physicians and increases in life expectancy. And actually, there is a less mortality inequality, and that higher poverty is associated with a increased impact there. So you actually get more of a response for neighborhoods that have even higher poverty. But it's not because all the Black physicians are caring for Black patients. So it's not necessarily aligned with physicians caring for patients. The authors hypothesized that having communities where Black physicians might live and raise their families might sort of be a surrogate factor for having life and wellness in those communities for the entire Black community, but also that physicians may be doing things other than clinical care, like advocacy and community engagement that lead to better health of those communities. Okay, so now getting to strategies, and I will admit that I don't have the answers here, just a couple of things that either I've approached myself or tried or thought about for us to consider for today's discussion. First, to acknowledge that there is a leaky pipeline, as we've described, both for women and for physicians of color underrepresented, that have been historically underrepresented. And so while for women, I think at least at the learner stage that we've made significant progress, as was even described in the University of Houston sort of medical school class, which is largely women. But for underrepresented in medicine, we have not reached the level of representation that we have in our communities traditionally. And it gets worse when you think about faculty, where the numbers dip to 88%, and the number of full professors and the number of deans and the like. So one program that we started at my institution, and have many roles, but one is as chief of medicine. I have about 60 or so direct reports, and some of my experiences with getting promoted, I didn't want to have happen to other of my colleagues that I was supporting. So we started a program to proactively intervene before they were getting ready for promotion, to make sure that I saw everyone if they were ready. And without going into details of this program, you can see that in 2013, when we started the program, 0% essentially of our women and URIM faculty, we only had one woman who had been promoted to full professor. And by 2020, the time that we sort of submitted this for publication, we had 25% of our URIM and 19% of our women who were at full professor. Then we wondered, well, maybe this is just a measure of time, that it was just over time that things would get better. People would get promoted from associate to full professor. So we looked at our School of Medicine, Emory as a whole. We looked at national averages for AAMC and did not see similar trends. So this intentional effort did, in fact, lead to increased promotion that was statistically significant. It raised all boats, so white men were promoted as well, but this intentional program had a disproportionate impact on women and people of color. So much so that now the majority of our faculty, 60% or so, are at associate or full professor. We had 100% successful promotion packets. 65% of our women, 42% of our URIM faculty are at senior ranks. And again, just want to make the point that this is unparalleled. The pipeline slides showed that 20% of women are at full professors, less than 1% of Black women, about 350 or so in the country are full professors. We now have 5 in our small unit that have been promoted with this intentional program. So I think this is just telling me that there are possibilities to do this. One of the other things that I've thought about, especially as you all are discussing the state level legislation, is just physicians getting engaged. I'm embarrassed to say, I used to cite this article all the time, that physicians vote less often than the general population. That is until the 2020 election, where now we vote about the same as the general population. But we need to do more than that. And that's not been our lane. We've thought about clinical care and that alone, but knowing that these broader medical drivers, that our physicians need to become more engaged in these issues. I think actually working within our accrediting body to set our own standards, our own professional standards about our values and who we should be as physicians, that would supersede any state legislation, right? So if we as physicians think that understanding diversity and having these courseworks or having a diverse workforce is important, that we should be able to set those standards. And I would suspect that state legislation would have to allow the accrediting bodies to that work to sort of supersede any state legislation. So that's one proposal I'd like for us to think about. The other thing that I've been working on with our institution is to implement coursework for our learners that, again, gets the learners out of the ivory tower to understand the broader impact of health and, through the curriculum. And so this is just a 4-year-long curriculum that we have integrated at Emory School of Medicine that helps the community to understand the broader impact of things that are going on. And so with that, I will just, that is really my last slide. I think I have good enough time. 2 minutes left. Okay, great. So I will end there. I'm not sure if the format, if we're going to ask questions at the end, but I want to thank you again for bringing us together and having this wonderful conversation.
Thank you very much for having me. My name is Mark Robinson. I'm the Associate Program Director for Internal Medicine at Baylor College of Medicine. And then I also wear another hat as Interim Section Chief for General Internal Medicine at Bentham Hospital, which is the largest county hospital here in Houston. And so with those two hats that I wear, recruitment of a diverse workforce is very important, both on the graduate medical education side, so that's when someone leaves medical school, they have to go to additional training, that's graduate medical education. It's very important we recruit a diverse workforce there for some very practical reasons. And then later, when they're done with residency and they're looking for a job, we really want a diverse workforce as well. And these are really practical considerations. As Dr. Bussey-Jones had talked about, there's a business case to be made and there's a patient care case to be made. This is not diversity to check a box. This is diversity to build the best physician workforce that we actually could come up with. So I have no disclosures, just any opinions I expressed are my own, don't represent Baylor College of Medicine and the Harris Health System. So first I want to talk about the benefits of a diverse workforce and just from the language perspective. So people in the United States speaking English less than very well, at least from census data, is about 8.2%. It's probably a little bit higher than that, probably significantly higher than that, but this is what shakes out in the census data. Looking at our hospital, the hospital where we take care of patients, our patient population is about greater than 50% Latino, Latina, and most of them are Spanish-speaking only. In any given year, we have about 80 to 90 different languages that are spoken in the Harris Health System. So it's very, very important that when we consider people coming both as residents or as future attendings, that they can speak the language that the patients speak and not necessarily have to rely on interpretation services. We have really robust Spanish interpretation services. We have great phone interpretation services for all other languages. But there is nothing that will substitute a physician who speaks the language of the patient in front of them. And so language concordance between patients and physicians improves outcomes across multiple settings. I had a resident from an African country taking care of a patient who was in the hospital for over 100 days for a very delicate social situation. And for some reason, he had some immigration issues that even our social workers couldn't quite tease out through the phone interpretation services. The resident happened to rotate on the service that this patient was on. They spoke the same language. And within the first day, she could communicate with him in a level that the phone interpretation could not. And she came out of the room and said, no, this is a very important immigration meeting that he has coming up because her family went through the exact same thing, the exact same process. And she could really tease out the nuances in a way that we could not using the phone interpretation services. It was really vital to have her on the service, and it really made a difference in his patient care. So language, so benefits of language. So this is a study, it's called the DISTANCE trial, and they did a comparison of glycemic control, so that's diabetes management, how well the sugar is being controlled among Latino patients with high and low language proficiency, low English proficiency. And so if you compare the top box, so the top box is people who speak English but identify as Latino, and then low English proficiency concordant, meaning that they don't speak very well English, they speak Spanish as their native language, and their physician taking care of them speaks Spanish as well. And there's actually no difference in the outcome, so there's no difference in glycemic control between those populations. But if you look at the very bottom box, so you have low English proficiency concordant, meaning their physician speaks Spanish along with the patient, or discordant, meaning that the physician does not speak Spanish, but the patient does. It's the odds of having poor glycemic control are almost 2 times, right? So you have twice the odds that the person's sugars will be out of control if they don't speak the language. Now, these are in clinics with interpretation services, right? And so I think that's really stark. So even we do the best we can providing interpretation services, but something is still lost. And so if you have that discordant language, you have patients who have twice the odds of having poor glycemic control, which is a pretty big difference. Oops, this slide. And this is another so it's not just Spanish, right? A lot of these studies will be talked about in Spanish, but this is a really interesting study out of Canada. And this was looking at the benefits of having a French-speaking population or French-speaking physicians in Canada. And so they did a study of frail patients admitted to the hospital. So I'm primarily a hospitalist, so this is really interesting to me, meaning I just take care of patients in the hospital. And patients with language concordance had decreased odds of in-hospital harm, so any mistake in the hospital, in-hospital death, and they had a lower length of stay. Right? If there was a hospital administrator here and said, hey, we can make this one little change and we would lower the length of stay, they'd say, here's a bucket of money, do whatever you can, right? This is very, very important. And the effect was actually seen in more non-French speaking patients, so patients that were even more on the margins of society in Canada than the French speaking patients. If you look on the graph on the side, you can see that these are pretty big differences. So this is compared to language discordance. Language concordance showed, again, Francophone decreased risk of harm. Oops, sorry. If you were allophone, so that's a language other than French, and you had concordance with your physician, you had a very, very high decreased risk of harm. So the odds ratio is 0.26. That's huge. That's a very, very big difference. And again, both length of stay and death. If you're telling me you can decrease length of stay and decrease risk of death in the hospital only by increasing the amount of physicians that speak the language of the patients they're taking care of, that's really important. That's an easy thing to do. Another thing I want to talk about is trust in physicians, and that's one of the benefits of having a practical consideration, right, of having a diverse workforce. If I could flip a switch and all of the patients in the hospital trusted my residents and trusted our faculty more, then yes, I would flip that switch. But we can, right? We can by hiring physicians, by recruiting residents who look more like the patients that they're taking care of. You know, I remember one story of this. He was a Mexican-American resident who was taking care of this one very elderly patient from Mexico. And the patient wasn't as sick as she felt. And her family was very concerned, and she was very, very concerned. And the other members of the team, you know, were not of Mexican descent, and they were trying to convince the patient, and she was really, really upset. And he just walked in, took her hand, and spoke for 5 minutes in, you know, the most gentle, fast Spanish that you could possibly imagine. He stood up and said, "Guys, she's going to be okay," and walked out of the room. And the patient was, you know, felt completely better and was discharged the next day, right? He had something more than language, right? He had something more than language. He could really connect with her and talk to her in a way that, through interpretation services, the rest of the team could not. So there is something about, you know, mistrust when your doctor does not look like you, and there is mistrust in marginalized communities for very, very good reasons against the medical field. You know, I was trained on the south side of Chicago at an institution that for a while took their trauma center away because it wasn't making any money and created a trauma center desert in an area with high penetrating trauma, right? And all of us physicians in training came there. We didn't know anything about that, but the patients did, right? And they would constantly remind us that, you know, the community maybe didn't have their back as well as we thought that the institution did. Through a lot of advocacy and activism, that institution now does have a trauma center back, and it really has made a difference in the community. But looking at race differences in items of medical mistrust, we see that compared to white patients, black patients have a higher mistrust, will report that patients have sometimes been deceived or misled by hospitals. The higher percentage strongly agree with that amongst the black community. Hospitals often want to know more about your personal affairs or business than they really need to know. Higher reported in the black community than the white community. Higher reported hospitals have sometimes done harmful experiments on patients without their knowledge. The difference here is 50% of Black patients will report this and only 26% of white patients. That's a deep historical knowledge in the Black community that the white community just does not have. Rich patients receive better care at hospitals than poor patients do, significantly higher amongst the Black community. And then male patients receive better care at hospitals than female patients do. And these are all statistically significant, right? So the patients are coming in with this baseline level of mistrust, right? That's a very strong weight. And so you really need a strong counterweight to that. And so one thing that we talk about often is Press-Ganey scores. Now, if this room was full of doctors and not lawyers, they would start throwing tomatoes at me and booing, that we're talking about Press-Ganey. But Press-Ganey is, they do a lot of physician surveys and see how well the physicians are scoring, at least from a satisfaction standpoint. And patients with racial and ethnicity concordance, so the same as the physician, are more likely to receive maximum Press-Ganey scores than discordant pairs, right? So just satisfaction improves. That's a counterweight to that baseline mistrust that people come in with. And if you look at Black patient and physician pairing scores, so Black patient and Black physicians pairings score significantly higher than when they're paired with white physicians or Asian physicians. And these numbers don't seem that different, right? So concordant pairs 4.71 and discordant pairs 4.68 or 4.65. If you've ever done any sort of satisfaction survey, everything's clustered really, really tight. And so the authors of the study note that a difference of 0.02 can change from the 100th percentile to the 70th percentile. And you can see that the difference between concordant pairs and discordant pairs is greater than 0.02. So that's a big, big difference. And again, when I'm talking about recruitment, when I'm talking about high recruiting residents and I'm talking about recruiting physicians to work at our hospital, this is a practical consideration. We want physicians who get better satisfaction scores. And this will happen if they tend to be concordant with the patients that they're taking care of. And it's not just that the interaction that people have, it's just that they trust people from the group that they're from, right? They trust people who look like them, who have lived a life like them. This is a really interesting study that was done looking at patient trust in online videos about prostate cancer. And so participants were randomized to watch the same video script, so the exact same words for 4 different speakers, right? A Black physician, a Black patient, a white physician, a white patient. And then they talked about prostate cancer screening or clinical trials. And what was really, really interesting, again, the exact same words, among Black patients, a higher proportion had trust with Black speakers versus white speakers, so they trusted the Black speakers more than the white speakers, physicians more than the patients, and then screening more than trials, right? Screening was seen as gentler than trials. So just seeing someone from your group talk about something, you're going to trust that person more. And so as a practical consideration, when we look, this is a practical matter. I want residents that will be trusted by their patients more. I want residents that will be able to speak to their patients more. And then one final study. So in a study of recorded patient visits of 252 adults, race concordant visits were longer and had higher patient positive affect than discordant visits. So concordant visit patients were more satisfied and rated patients as more participatory. And again, the measurements of patient-centered communication behaviors did not explain the differences, right? So if we measured how well they communicated, it actually showed no difference. But it was just the fact that they looked like them, they came from a community like them that led to the trust. And so we can do a lot of training for our workforce, but that is not a surrogate for having a workforce that looks like the community that they're taking care of. And so with that, many patients in the United States have low English proficiency, and when physicians speak the same language, outcomes are improved in a fairly dramatic fashion. And then non-white patients have higher levels of physician mistrust, and this could likely be improved by increasing the number of physicians of similar race and ethnicity. Thank you very much.
Good morning. My name is Angela Heads. I'm from the McGovern Medical School. I'm a psychologist there, an associate professor, and as mentioned, a co-director of the Behavioral Health Equity and Outcomes Research Center there. And so I wanted to talk a little bit about medical mistrust and cultural humility. So I'll talk a little bit about some sources of healthcare disparities, the importance of cultural humility in health equity, the role that medical mistrust plays in healthcare and engagement, and systems level approaches that we could use to address medical mistrust. So this is, start out this first slide here just to kind of look at some sources of healthcare disparities. And so what this is showing that even among populations where there is equal access to care, there are differences in the quality of health care between minority populations and non-minority populations. Some of that has to do with, we'll say a small part of the disparities have to do with the patient's preferences for treatment. But the bigger part of that has to do with the kind of culture of the healthcare system and environmental factors. And an even bigger amount of it has to do with discrimination. And so the experiences of bias, stereotyping, uncertainty, which comes from the providers themselves and is perceived by the patients. And so this kind of sets us up to talk about why culture matters. We've talked about it in a few ways today with the mistrust and physician-patient concordance. I'm a behavioral scientist, so most of my work is with people who are like in mental health therapy or substance use disorders therapy. And there's a lot of stigma that comes along with that. And so when I am training people in how to do this work, talk a lot about culture. And so I'm framing this talk in that way. So culture is really important. So it plays a role in how we as people engage in our self-expression, our help-seeking, how we cope with things, how we engage in social support, and it affects every aspect of an individual's life. Culture is everything. So we talk a lot today about race and ethnicity, but it's more than that, and it's more than even what's shown here on this screen. So when we're considering culture, we're talking about the gender, age, socioeconomic status, religion, sexual orientation. We've mentioned language today, disability. All of that is important to consider when we're working with our patients. If you've ever been in a multicultural class of any type, we talk about these things and we talk about the importance of cultural awareness and cultural competence. And basically, cultural awareness is just that. It's really you recognize that people are different. You recognize those differences. You have maybe a basic understanding that people bring these different experiences with them based on their own unique cultural context. And that's great. I always challenge people to go a little bit further than that. And one tiny step further is cultural competence, which basically says that you understand that these differences exist. You know that there are things that should be done differently because people are different. But the competence implies that you kind of know how to effectively operate within those different cultural contexts. Cultural competence is fine. It's not everything. I say that the main limitation of cultural competence is that we think that there's an endpoint. So as physicians, attorneys, psychologists, it's really important not only to just to not stop at that competence piece, but to move on to the next step, which I'll talk about in just a second. In organizations, cultural competence is the organization's ability to respond to the unique needs of members of diverse populations. So we're in medical healthcare settings. What do we as an organization do to make sure that those people who come to us with these different social contexts have the things that they need? So we've already mentioned language, having the appropriate language there, not just picking up a phone and having an interpreter, but having an actual person in front of them can be really valuable. Being sensitive in the ways in which people experience the world is really important for an organization. So as I mentioned before, the problem that I have with cultural competence is that it suggests that a person can obtain and have complete accurate knowledge about a group of people who share that culture, and that is just not possible. The problems with this is that we may go to our multicultural class and decide that we know that because an African-American Black person is in front of us, that we know what needs to be done in that particular situation. And it doesn't consider all of the different intersecting identities that this person may have other than just their race or ethnicity. It suggests that there's an endpoint, and there is not. And so what I challenge people to think more about is to take a stance of cultural humility. And so that includes all of those things about the knowledge and the competence, but also it leaves us open to learning more. Understanding the complexities of the identities is a major important factor in these situations. Encouraging curiosity. So concordance is great. So if I were only to see Black clients, I might be a little bit limited in the number of clients I can see. But when I walk into a room and I see someone who is different from me, having that curiosity, just being able to ask the questions, like I see that we're a different religion, can you tell me a little bit about your religion? That opens up the areas of trust that we've talked about. It opens up clients to be more honest about their conditions. I'm saying clients because of my behavioral health background, but patients as well. In medical settings, if a client doesn't have that trust, a patient doesn't have that trust, then once you start asking some questions about who they are and their identity and what's important to them, it opens up trust. They're able to provide you with more information. You're able, if you're a physician, to provide them with the care that they need. So cultural humility recognizes that we as clinicians will never be fully competent, but we can make some steps towards understanding our clients. All right, so if you have cultural competence and cultural humility all together, then you can recognize how the cultural values relate to health-related beliefs. You can understand the incidence and prevalence of clinical conditions among diverse populations that we serve. And you're familiar with the data on treatment efficacy among diverse populations, which becomes very important when you're in the clinical setting. So we've talked about having a more diverse workforce, and that is a start. It doesn't completely solve the problem, but it's really important. As has been mentioned today, bias is kind of inherently built into our systems of care. Having providers who promote health equity and work to improve access within their systems, and themselves also work to demonstrate cultural humility and competence is an important step towards bringing the competence and humility in healthcare and restoring trust that our clients and patients have for us. It's like we're doing this from the inside as clinicians. Dismantling these biases at the system level requires us to have a lot of conversations and recognition of the problem. So we've talked about medical mistrust a little bit today. Patients develop medical mistrust in the healthcare system when they experience things like bias, discrimination, and barriers to quality care. Patients who lack trust in the healthcare system, and that includes the staff, the physicians, the processes, the research, all of that goes on in these healthcare settings, are less likely to adhere to treatment and more likely to have poorer health outcomes. So having experienced discrimination or knowing that discrimination and bias is possible within that medical setting leads to medical mistrust, affects health behaviors. A lot of the work that I do, like I've mentioned, mental health, substance use, I also do HIV prevention. These are highly stigmatized medical conditions. And the behaviors that we want to see in our patients, we want to see them showing up for therapy, we want to see them taking their medications. If they're HIV positive, we want to make sure that they stay on their ART. If we don't have a good connection as clinicians with our patients, then we won't see those behaviors that we want to see. So medical mistrust, it's more than just a lack of trust in the system and the providers. It also includes the beliefs that the medical system may act in ways that harm certain groups of people, and that's been alluded to earlier today. There are certain populations within the United States who are very well aware of injustices that have occurred in healthcare settings and in research. Some people are not aware of that, and it may not be an issue for them, but for those who are aware, they tend to shy away from seeking care. They tend to shy away from being involved in clinical trials, which also limits how we can better improve our healthcare systems in the future. And because of that awareness of the things that have occurred in the past, we might actually consider this medical mistrust to be an adaptive survival mechanism. So it's not that you're not paranoid if it's true, is what they say. These things have actually happened in our past, and it's important for us as providers to be aware that our patients are also aware of those things that have happened. So there are some systems level approaches to addressing medical mistrust. Some of them have been mentioned today. So having staff that reflects the population by increasing the numbers of providers that are underrepresented in healthcare can be an important step. And having an organization that is committed to becoming an inclusive and equitable organization is also a very important part for addressing system levels approaches. So, in summary, medical mistrust has been addressed by providers and systems in order to improve health outcomes and reduce disparities. When we see that being done in certain settings, we see improvements. Having medical staff that reflect the population being served can also decrease health disparities. All providers can practice cultural humility to increase trust and improve health outcomes. And I will stop there.
You can hear me. So I'm Jane Hamilton. I'm an associate professor at McGovern Medical School. I co-direct the Center for Behavioral Health Equity and Outcomes Research along with Dr. Heads. And since 2018, I've been the director of the UTHealth Homes program in Houston, where we deliver integrated behavioral health treatment to people experiencing homelessness. And as many of y'all are probably aware, there's an overrepresentation of racial minorities among the homeless population. So we really have developed a lot of best practices around delivering evidence-based, culturally competent care. So I have no disclosures to report. The learning objectives for today are to hopefully to demonstrate increased knowledge of health disparities among racial and ethnic minority populations. While race concordance has been discussed, I'm going to present a little bit more research and discuss some of the gaps in this research area, and also to describe how a diverse healthcare workforce can improve access and outcomes in healthcare. So we've talked about health equity. So when we think about health equity, we're thinking about a healthcare system, and really a system where everyone has a fair and just opportunity to attain their optimal health. And as has been discussed today, when we think about health, we think about it broadly. We think about social determinants. We think about population-level health outcomes. And so there's an underlying principle to really reduce and ultimately eliminate health disparities and the determinants. And for people of racial and ethnic minority groups who have been historically excluded, underrepresented, or mistreatment, oftentimes what we see are a failure of multiple systems and cumulative risks that accumulate over the life course. So when we think about how we would address health disparities, it's complex, and it requires really a recognition of the need to really change the system in a way to where we're focusing on the communities as people are discussing, but then also really looking at the patient experience of care. Because through this historical mistreatment, there has been a withholding of medical treatment and ignoring health concerns. And that's one of the issues that we really focus on with our program, is to really spend a lot of time listening to individuals, understanding where they're coming from, and to really measure symptoms. So we deliver evidence-based care, and I think where we've really made a difference in our community is to use validated assessments, to look at outcomes, and to really take the time to measure things over time, because this has enabled us to continue to be funded, but then also to kind of set like a standard that I feel like is needed when we're working with these most vulnerable groups, because recognizing, as the panelists have discussed today, that we're working with groups that often haven't received preventive health services. So for example, we're funded by the Substance Abuse and Mental Health Services Administration, and we had to establish regional goals for eliminating health disparities. So one of our goals was to look at racial minorities over the age of 50 and to make sure that every person that we enrolled that especially with racial minority males, that they're receiving all needed cancer preventive screening. So this is something that is in a way kind of outside the box for homeless service providers, but we are monitoring this as a region, recognizing that there's been a lower quality of care and worse outcomes for certain conditions among racial and ethnic minority populations. And as many have mentioned today, there's an underrepresentedness in clinical trials, which is important because when we think about medical, when we think about medications, services, they should be representative of everybody who's going to receive the services, but we really have a small number of people that have been participating in clinical trials. And so with race concordance, as has been mentioned, we're talking about a shared identity between medical providers and patients regarding their race. And the research really has focused on communication and also satisfaction with care, which has been mentioned, but also partnership building and the length of visit and the talk time ratio. So those are some areas where there needs to be more focus across all services, that if there's a systemic bias to where certain people are not receiving the needed time or information, that's going to drive a lack of adherence. And so I've conducted research on medication adherence, and really the largest factor driving the non-adherence is the communication between the patient and provider. And so this really highlights the importance of training physicians and other healthcare providers to engage in higher quality communication with racially and ethnically discordant patients, really by focusing on patient-centeredness, improving information giving, partnership building, as well as engagement in the communication process. So we had a grant from the Patient-Centered Outcomes Research Institute where we looked at what was driving non-adherence among different populations in Houston. And one of the focus groups we conducted was with non-English speaking Latinx individuals in an area at a community center in Houston. And what we found was a lot of distrust of healthcare providers, and what was really driving their, almost looking as if the provider was an authority figure that they could not be honest. And so that was one of the things that we found, is that maybe there were some barriers around being able to afford medications or understanding how the medications should be taken, but there was a reluctance to really disclose their concerns. So it's really, I think, for all of us, it's important to think about what our patients may not be telling us because they don't really feel like we'll understand, or that we may judge them harshly. So this was an important finding. And then really in my area, I work in mental health. I'm a health services researcher. And so as has been discussed today, compared to the majority population of non-Hispanic whites, members of racial and ethnic minority groups in the US have historically been less likely to access and utilize outpatient mental health services. So that's when we deliver outpatient mental health services, we go to the communities where people experiencing homelessness are more likely to receive other services, and we've been able to successfully deliver services to 540 individuals and engage them in long-term treatment. And our goals are to not only deliver behavioral health care, but to connect 100% of our patients to primary care. And we monitor this over time. So thinking about limited access to community-based services, this is going to result in higher emergency department visits and inpatient hospitalizations. And then even with access to mental health services, many racial and ethnic minorities are more likely to receive lower quality mental health care. So within the mental health field, this has been researched more, the race concordance. And the findings have shown that patients have higher levels of perceived satisfaction of care, quality of health care, and more trust in their providers. So when we're thinking about behavioral health workforce shortages across Texas, we need to think about that within the behavioral health workforce, we have severe shortages of providers, with almost every county in Texas being designated as having a behavioral health workforce shortage. But then we also have very few numbers of minority behavioral health providers. So it's something that we're really working on. So some of the strategies that we use to increase diversity is that within our center, I mentor a lot of residents, medical students, PhD students, public health students, and I also try to sponsor a lot of diversity applications for research grants to see how we can always combine what we're doing to improve the way we're delivering healthcare. Another thing I'm going to talk about is we bring people with lived experience onto our team and at all levels. So this is a strategy that SAMHSA, our funder, really believes in. So we even have not only do we have providers that have lived experience with homelessness, but also our program evaluator has lived experience with homelessness. I feel like this has been very effective. And that, really trying to think about how we can equitably deliver care. And we also had a program last year where we have a McGovern Center for Humanities and Ethics, and we received extra funding, and with our medical students, we had a luncheon at a permanent supportive housing program in Houston, where we brought medical students together with people that had formerly been chronically homeless and were in permanent supportive housing to really bring together the students and the people with lived experience to talk about how what are their experiences like, and just to have some community and to have lunch and to think about over time, maybe this would, bring in like a different perspective for the medical students. We work a lot on reducing implicit bias. We do implicit bias training. Another strategy that we're using as a part of our new grant, we've committed to training 500 providers in Houston in what are called the national class standards. So this is from the U.S. Department of Health and Human Services. They've established guidelines for delivering culturally and linguistically competent healthcare. And so we are working with the health departments and our medical school and providers across Houston, including the Coalition for Homeless, to train 500 providers in delivering culturally competent care. Because really with the, most of my experience in recent years being with the homeless system, as I said, we're really dealing with the failure of multiple systems. So while healthcare is part of it, we also often have a failure of legal system where people haven't gotten the legal representation that they need. They may have a criminal record that's serving as a barrier to housing. So we really are trying to holistically train people in cultural competence and engagement of our patients to make sure they're able to navigate these systems and, and to achieve health equity. So, thank you.
Thanks very much. We now welcome your questions both on the floor as well as online. Dean Baines.
Thank you. That was a wonderful panel. One of the things that we do in the law school, and I wonder whether it's something that the medical schools do, is that we have a number of students who have some degree of Spanish or other language competency, but sometimes it's not that great. It's not that strong, and so we try to encourage it by having a course for those who want to have more professional Spanish. And we also send students to competitions that may be all in Spanish. There's like an international arbitration commission competition that students have participated in. And we also have we started our own bilingual negotiation competition, with 2 schools in Mexico. So it really allows our students who have that proficiency to make it stronger and better. And I wonder if the medical schools are doing something similar.
Thank you. And this might be an opportunity to think about what the opposite of inclusion and diversity are practices of exclusion, and what are some things we can do to address exclusion in medicine, medical practices, and education in today's political climate. What are some bold things we might do, and what are some small incremental steps we might take? So is there another question? If not, I have.
Well, I was just going to respond to the comment that you mentioned. I think that what you mentioned is really important. Our medical learners oftentimes now, when I was in medical school, we went straight through. Now our learners have gap years. They're working 2 or 3 years. They're traveling abroad. They are learning Spanish, being embedded or immersed in these programs. But we want them to, before they are considered to be, concordant, they have to go through classes. They actually can be interpreters. We do this for our undergraduate learners as well before they can come into the medical encounter, and using their own Spanish. They have to be tested. They have to sort of get a certification before that's used. Otherwise, we even require them to use interpreters. But there are some curricula to supplement the Spanish speaking that our learners do, and then certify them for their ability to actually engage with patients using their level of Spanish to see if they're good enough, so to speak.
Yeah, I think that was helpful because it talks about intersectionality. It's not just one dimension of language. It's also culture. It's also just the way we present ourselves. So thank you.
We've had a lot of student-led effort. So we have a medical Spanish program, and then we've had a lot of students say, hey, our language is not represented. So we had students create an Arabic elective, medical Arabic elective, same with medical Chinese as well. And so very often it comes from the bottom up, which is how it should be.
Yeah, I would just answer your question as well. There's almost several schools in Texas. So, for instance, San Antonio, they have a whole course through the University of Tilman at Guadalajara that the students can take, faculty can take, everyone can take to get proficient. We have Fertitta de Salud, where students actually engage with going to Mexico, working in Mexico, and improve their Spanish. So there's a lot of programs like that. I was just going to ask a question. There was a period in this country where there was federal funding to help improve diversity and funding and creating centers of excellence. Do you see those centers as having an important role, and have you seen some of the decline that you reported representing how we backed away from federal funding and support for centers of excellence at schools of medicine around training underrepresented minorities?
So I think by any means necessary. So I know that we have had HRSA funding, I think is what you're referring to. There's probably other funding avenues. We have had HCOP programming. We've had a lot of the primary care training programming, which always has an emphasis on diversity. That's one of the areas where we do well, as well as primary care, some of the things that you all are doing very well. I think that those programs are essential to my estimation, but also that we need more. We have seen the benefits of those things. We have, at our institution, have, leveraged some of our funders, specifically not around diversity of workforce, but around primary care, but sort of having people specify values, whether it is diversity of workforce, which HRSA has really leveled that as one of the things that they want to work on, caring for underserved, vulnerable populations, and primary care. And I've seen direct benefits from those. We've had sustained funding in those spaces over time.
Anyone else in the audience care to reply to that? Okay, please.
Hi, I'm on faculty at the Law Center, and I was monitoring the chat. So I'm reading you a question from someone who is attending online. And It says, I'm troubled by any implicit argument that difference in Press-Ganey scores could serve as a compelling interest for race-based hiring. I've looked at the 2020 study you reference, and it shows that white patients rate encounters with non-white physicians lower than with white physicians. So, accepting your argument would say that hospitals that serve mostly white populations should discourage the hiring of minority physicians. If not, it is implicitly embracing the asymmetric treatment of racial classification that the Supreme Court has rejected. Second, when I look at the study, the differences may be statistically significant, but they look quite small. There are lots of differences that are statistically significant, but not practically significant. Using percentiles is cheating. Low scores will always be at the 0 percentile, and high scores will always be at the high percentile.
No, thank you for bringing that up. I mean, again, most of the yes, Press-Ganey scores we should always take with the biggest grain of salt you could possibly find. But they are one of the main drivers of patient satisfaction in the majority of hospitals in the United States, right? And so it's something that, yes, I don't think it would be the be-all, end-all for any sort of diversity consideration, but it is what is out there. And so I do think it has to be used. And then, yes, the numbers are very small, but again, the authors say, whenever you do any sort of satisfaction distribution, they're very tight, right? If you've ever done any sort of satisfaction survey, anything, it's always clustered around a really, really tiny area. And so, yes, the numbers are small, but they are statistically significant. And as the authors note, they do drive the percentiles down considerably, right? And so, and we do often say when we're in the 100th percentile, we're more than happy to say, yes, our Press-Ganey scores are in the 100th percentile. When our Press-Ganey scores are in the 70th percentile, then we say, oh, we don't care at all about Press-Ganey scores. And so I think we do have to be a little bit honest about that fact. Yeah, and then back to that study, yes, there are some interesting differences about white physicians and white patients and white physicians in when they have different races. And I think those are something that should be considered, but just for the sake of our discussion here, I focused on the Black concordant patients.
Hi, okay, this is on. So I want to first say thank you to the very kind people who let me skip in front of them because my comment was relevant to this particular question. So I would also push back to the person who asked that question, which I think is an incredibly thoughtful question, to say that satisfaction oftentimes is a proxy for trust. And what we know is that historically, people from minoritized communities have lower levels of trust in the healthcare system, and rightfully so, because we have long-standing health disparities due to systemic issues. And so while I understand the person's question about concordance among white patients and white physicians, white patients have not experienced the inequities that persons from minoritized communities have experienced, nor have they experienced the health disparities that minoritized communities continue to experience. And so when we're talking about this, I don't think that it's an either or. It is thinking about how we create an equitable healthcare system for patients who have historically been underserved, not well served by our healthcare system, and as a result have had lower life expectancy, more morbidity, more mortality, because of things that are inherent in our healthcare system. So I just wanted to respond to that comment and say, while I understand what they're saying, I think that we may be conflating the issue when we're thinking about how to improve healthcare for individuals from minoritized communities.
I also want to say, when you look at some concordant studies, so there's a study out of the VA looking at, I think it was a lung cancer or cancer, working with oncologists. And in the study, they couldn't find concordant pairs of Black oncologists with Black patients because at that institution that they were studying, there were no Black oncologists, right? And so very often they can't even do the studies and they have to take some pretty big statistical leaps to even try because there just isn't the specialists available to be part of the studies. Thanks for bringing that up.
Thank you for the panel. So my question is about medical education. As a law student, I've learned about a pretty robust anti-discrimination law framework that seems like it would be relevant to addressing some of the disparities which were described in your presentations. And I've also read studies that generally medical students and physicians are unaware of these legal obligations that exist. And so given the scarcity of time outside of the clinical curriculum that is obviously the priority in medical school, do you think that there should be an increased focus on the legal side, on critical theory, on some other medical humanities aspect, or what would be the most effective use of elective time outside of the clinical studies?
I may start with that, and then I'd love to hear your thoughts as well. I know when I was a medical student, now it's 3 decades ago, but I spent 8 hours a day in a classroom like this. Now, of course, most of the anatomy, the physiology, the pharmacology, we can look up on our phones. And so I think one of the things that I was describing is that getting our learners out of the ivory tower, thinking about some of these things more healthcare more broadly, because really smart people can learn some of the medical facts in a lot more facile way. And so I think it's really important. We have, again, integrated these concepts across 4 years, perhaps not as focused on the legal aspects, but talking about bias and discrimination and trust and culture and language and history in ways that I didn't learn at all in medical school, but I think that we can do more, because I do think that people in your generation are going to have to solve these problems, and especially for health professionals that we can no longer stay in our quote-unquote lane, our clinical lane, that we have to be able to engage with our systems, our structures, our policymakers, our communities, to think about health in this broader context. So,
I'd just like to say one thing. When we wrote our original grant to treat homeless individuals, we developed a medical legal partnership. And as part of medical education, we always have medical students on the team, and we work with a legal clinic in Houston called the Beacon Law to really provide some firsthand knowledge on how the population we work with is really often not able to access needed medical services, housing, other benefits because of legal barriers. So that's one small thing we do. And we also try to integrate this knowledge into our teaching, because we teach a lot of social determinants of health courses, so we do touch on this regularly.
Thank you.
Good morning, and thank you also for this panel today. My question pertains to medical mistrust. So I also am a law student at UHLC, and we've studied a lot of case law about doctor-patient relationships that may lead to mistrust due to these past harms. And so my question is, in addition to promoting greater representation in healthcare, what are some specific actions that physicians can incorporate into their practice that are able to prevent these future harms? And maybe do you have some examples that you implement in your own practice?
Yeah, so I work mainly on the hospital side, and one thing that our hospital is pushing is actually just sitting at the bedside, right? And so, which seems like it should be very obvious, but if you've ever worked in an academic hospital, it is not. You move in and out of rooms very quickly, and so just making it a requirement that you sit at the bedside, and there's a chair against the wall, and you are required to take it off and sit down next to your patient. While you talk to them about their care and talk to them about what happened overnight and where things are going. And that's a small thing, but that's, as we talked about, how a lot of the discordant pairs show that you spend less time with physicians. So actually kind of forcing it to make a systemic change that you are forced to spend more time at the bedside next to them at an equal level is a small change, but that's something we're doing at Bentob.
I'll just add that, acknowledging that I believe that health professionals bear the onus in building trust in our patients. Oftentimes the mistrust is not only perceived in the healthcare, but also things that happen outside of the healthcare space. So their interactions with policing, housing, education, and all that is brought into the healthcare environment. And so, but we bear the lion's share of building trust and showing ourselves to be trustworthy. Oftentimes, it's difficult, especially if there is any anger, or people are at their worst sometimes when they're not feeling well, and so sometimes that can sort of get a conversation off to a bad part. But if we can work to, with trauma-informed care, that's another intervention where you actually understand what has happened to patients and listen and engage and give people grace and do our best to show ourselves trustworthy, then that's been sort of helpful from our end. But really understanding, again, the broad context in which our patients are coming from.
Thank you for that question. I think it brings up that incorporation of peers, advocates, and community health workers can also be an important factor to give people voice where they may not have a voice. I also would like to speak to the concordance discussion in a maybe more simple way. Viewing concordance can oversimplify and remove the intersectionality that focuses only on gender, race, or some single factor. Shouldn't patients be able to select the characteristics most important to them? But that's pretty hard to do when we have a profoundly underrepresented workforce. So just a less statistical and more simpleton view.
So, terrific panel. Thank you so much for your comments this morning. So, some groups that are opposed to medical schools taking into account an applicant's race or ethnicity will argue that undergraduate GPAs and MCAT scores are predictors of student success in medical school, as well as their success following graduation when they enter the medical workforce. And therefore, if a medical school was to admit a student from an underrepresented population with lower test scores than maybe the white applicant or the Asian applicant, that student is going to be less competent in medical school and as a physician, and will therefore provide lower quality care to the community, including underrepresented communities. And I was wondering if you could directly respond to that argument.
I think that's a great question, and honestly, I don't have all the evidence there. I will just say something anecdotally here, which is that never ever have I had a patient ask me what my MCAT score was or my GPA, and if you think about this for your own doctors, you would say the same. But there are studies that show how patients define what a quote-unquote good doctor is. Again, has nothing to do with any scores or even, I would argue, proficiency or skills. It's more about sort of how you connect and listen to patients. I can tell you, the one thing that I do think that there's evidence to support is that the MCAT does not predict how good a doctor is going to perform in their residency or their clinical training. It does predict your ability to pass other standardized tests or do well on other standardized tests. But again, I can't say for law students, what, because of the careers are so different, but this idea of working with patients and communities, that there are so many other things that are valued for the patients than some relatively arbitrary GPA or line towards an MCAT score. And I also think that it's a false choice, that there are lots of people that I know that have great GPAs, great scores, and are people of color. So I don't necessarily think that's a good choice. And then finally, I will say that for my husband is a surgeon. He had a pathway that was very different from me in the sense that he did not get into medical school on his first or his second try, had a difficult time with his college GPA, went on for some more graduate programs and did very well. But he went on to do general surgery, then trauma and critical care, and has a nonprofit to help the pathway of people who are getting into medical school, is beloved as a professor of medicine and with his patients and the like. The value of him being in the healthcare profession, I think, is intangible. And so I think, I can't speak to you. I don't know the evidence around the scores, but there may be other people here who can say that. But I can tell you, just again, from my own anecdotal experience, someone who did not initially have the perfect GPA, who is a wonderful doctor and a wonderful colleague, and also that, again, my patients have never asked, or nor have I as a faculty member working with learners, the people who did the best on their MCATs and their GPAs may not be the best clinicians. So that's the only sort of more anecdotal without empiric data that I can speak to. I hope that someone else has more information there.
Could I weigh in on this?
Yes, please. Help me out.
I'm Leon McDougall, Associate Dean for Diversity and Inclusion and Chief Diversity Officer at The Ohio State University. And so, regarding the question, the Supreme Court has already made the decision whether or not race can be considered as a variable in admissions. So that water's under the bridge. I really want to highlight the fact that proficiency is important. We have to pass boards, family medicine boards, boards to get through our curriculum in medical school, and I believe there's a thing in law called the bar. Okay, so I just want to emphasize that quality is important, proficiency is important, and so that's part of my answer to your question. You're going to hear the rest later on today.
One thing to think about is, medical students, very often they'll go to straight through undergrad, straight through med school, and then in a residency. And, we've all had doctors with, a lot of life experience and doctors who are fresh out, right? And there's a difference, right? We went to a pediatrician for a while that didn't have kids, very different than a pediatrician who has kids and can give you a little bit more realistic view. And so we don't have a lot to go off of, right? And so when we recruit for a residency, one of our big clinical sites, we have the largest VA in the country. So if someone comes from a military family or went to a military college or has a military background, that's important, right? Because our patients will trust them more. And I don't think anyone would say, how dare you diversify your class with people with a military background, right? But the patients trust them more, and they connect with them more, and they speak the language more. So it's a short amount of data to go off of. And when people are able to have a diversity of experience in that short lifespan prior to entering their training, it's important to us. So it's a hard question.
Good morning. I'm Jeff Young. I'm from the Association of American Medical Colleges, and I'm the Senior Director for Transforming the Healthcare Workforce. So I just really also want to just add on to what Leon said. I've had the honor of serving on 3 admissions committees at 3 different medical schools. And I can share with you that not one time did we admit someone that we didn't think was qualified or was going to be successful. That's number one. The MCAT score and the GPA, the MCAT really tests your knowledge and your readiness for academic medicine. And we also have to take into consideration that there are real educational inequities that may impact multiple communities. And so I think when people think about scores, they confuse that or conflate that with merit, right? Scores don't always mean that you will be the best or the most competent physician. It means that you are academically prepared and that you have a history of being successful on standardized tests. The other piece that I would just share, that it's really important to recognize that one of the things that we at the association emphasize is the value of holistic admissions, that the admissions process and the core criteria are inexplicitly tied to your mission. And so if you want to train physicians who are going to be able to work within a community or whatever the mission is, then your selections should reflect that. In addition to, obviously, GPAs and scores of your standardized exams, But ultimately, we're really thinking about the experiences and the attributes that someone will bring to the medical, not only the medical education, because we know that diversity increases likelihood that there are going to be good conversations, that innovation is better. And so we have that data. So I just want to emphasize that when we think about this, don't get it twisted, right? That we're really talking about the whole person, the whole person. And
I think it's
to
very
your point,
important.
I think that's, your husband reflects that beautifully.
Absolutely.
Yeah, not just one category, but the whole. Thank you very much.
Hello, my name is Elvina, and I'm currently an undergrad at the University of Houston. I'm a part of the Medicine Society minor at the University of Houston. We focus a lot on social determinants of health and how that impacts patient outcomes and health outcomes. Dr. Bussey-Jones, when I was listening to your presentation, I also noticed that you had mentioned that law and policy also impacts healthcare disparities. So I just wanted to know what specific laws or policies may impact healthcare disparities. Thank you.
Yeah, I mean, I think this is maybe a question for our law colleagues, but I just mean that over the years, there have been so many laws. And yesterday in Grand Rounds, I talked about that my grandparents, for example, that they lived in a segregated town. So that meant that they could only get a grade school education. There was no black school past 6th or 7th grade. Both of my grandparents died of what I now know as preventable conditions. So because they didn't have access to a physician, and so that impacted their health. Education is tied to life expectancy. Income is tied to life expectancy. That law of segregation, of the lack of investment in that community is just one example. But we talk about redlining. There are so many laws. Like I said, our law colleagues could talk about this even more when it comes to that as well.
Also, the absence of a policy is a policy, right? So, like, the absence of Medicaid expansion in the state of Texas is a policy decision, right? So if something doesn't exist, well, it doesn't exist because people have decided for it not to exist.
Yeah. And I would just want to add that I think our second panel today will probably address the question that was just asked. So I hope you all stick around for the second panel. And with that, I think we are out of time for this first panel. Just want to thank you all so much. Really terrific presentations today.